Hello, thank you for watching this video. I am Christophe Ezod from Henri Mondor Hospital in Paris, and I am very happy to discuss with Maria Buti from Barcelona on a very important message on viral hepatitis. So, Maria, we will discuss HIV treatment, and I think that you have very interesting studies on this topic.
Thank you, Christophe. In this meeting, we have got new information on genotype non-1. The majority of studies looking on genotype non-1 are in naive patients, non-cirrhotic patients, and they evaluated shorter treatment duration, 8 weeks. Terika Sala presented the results of grazoprevir/elbasvir in genotype 4 patients, naive, non-cirrhotic, genotype 4, treated for 8 weeks. This is an ongoing study, and he showed preliminary results, 8 weeks of treatment for genotype 4, almost 100% sustained virological response. In the same line, there was another study in genotype 5 and genotype 6 with glecaprevir/preventosvir. As you know, in the registration studies, the number of patients infected by genotype 5 and 6 with glecaprevir/preventosvir were low, and now we have more information. 70 patients treated according to the label. 8 weeks for naive, non-cirrhotic patients, 12 weeks for cirrhotic patients with the GP regimen, and again, almost all with sustained virological response. And the first combination that I would like to discuss is a study performed in Scotland in genotype 3 patients, naive patients, non-cirrhotic patients, treated here with sofosbuvir/velpatasvir, 8 weeks. These are a bit difficult to treat patients because the majority of them were under opioid substitution treatment. And all of these patients, 90 patients, all of them achieved sustained virological response.
So, do you think that the new treatment duration for naive and non-cirrhotic patients could be 8 weeks? Because you show that probably 8 weeks it's possible for grazoprevir and elbasvir for genotype 4, glecaprevir 5 and 6, and now sofosbuvir and velpatasvir 8 weeks for genotype 3. So what do you think?
I think probably we are over-treating some patients. I think this data clearly make us more confident if patients are not very, very well adherent to treatment. Clearly indicate that if some patients miss 1 or 2 pills, the majority of them are going to achieve sustained virological response. It's another way to know that these are very, very good drugs for hepatitis.
And so, do you think that for genotype 3, because it's a very important genotype and difficult to treat genotype, that we can really treat for 8 weeks the naive patients with sofosbuvir and velpatasvir, and by contrast, in cirrhotic patients, to use sofosbuvir, velpatasvir, and voxilaprevir for cirrhotic patients?
I think naive genotype 3 patients, non-cirrhotics, are easy to cure, and I am happy with 8 weeks regimens. I know some of them, the label recommendation is 12 weeks, but I think genotype 3, we can cure the majority of non-cirrhotic patients. Regarding cirrhotic patients, there is a nice study that has been presented by Rafael Esteban. It's a study performed in Spain. It's around 204 genotype 3 patients, all cirrhotic patients, some of them naive, others treatment experienced. And these patients were treated with sofosbuvir/velpatasvir with or without ribavirin. It's a randomized study, and the endpoint of the study is to look if ribavirin increased sustained virological response in cirrhotic patients infected by genotype 3. And the study shows very high sustained virological response. 91% overall in an intention to treat analysis for sofosbuvir, velpatasvir, slightly high for sofosbuvir, velpatasvir, ribavirin, 96%. So it seems it's a numerical advantage to add ribavirin. But if you analyze the data regarding the presence of baseline RAPs for NS5, if the patients didn't have RAPs, sustained virological response, in cirrhotic patients, naive of treatment experience is almost 100%.
Yes, because we have seen that there is an impact of the Y93H mutation, and especially in cirrhotic patients. So if resident testing is not available, because we know that in some countries it's very difficult to have resident testing prior starting treatment. So do you think that you can treat with sofosbuvir and velpatasvir without ribavirin, or do you think that you must add ribavirin? And in case, or if resident testing is available, do you think that it could be a good option in genotype 3 cirrhotic patients?
As you know, the prevalence of NS5 RAPs, it's very different in different countries.
Right.
In Spain, it's around 20%, but 20%. In another countries, it's much lower. And this clearly impacts on the results. And I think it impacts with sofosbuvir, velpatasvir, but also with other regimens. So if you don't have RAPS testing, you can add ribavirin. This is an option. Another option is to go to triple therapy with sofosbuvir, velpatasvir, boxilaprevir. And another option is to use glecaprevir, preventaspvir, now 16 weeks, and could be another 4 option. Treat with sofosbuvir, velpatasvir, and if the patient fails, this is around 5%. It's not too high. Then you can retreat with sofosbuvir, velpatasvir, boxilaprevir, because now we have data that you can retreat these patients with an excellent sustained virological response.
Do you think that it could be possible to treat patients with compensated cirrhosis for 8 weeks? Is it for you something that we can hope? Or do you think that there is studies on this topic, or it's not very important for you?
In this meeting, there has been 2 late breakers oral abstracts on glecaprevir, preventaspvir. One study performed in Italy, and another study performed in Germany. And Thomas Berg presented the data, or the fair real world data, on this combination. In the majority of patients were naive, non-cirrhotic, and treated for 8 weeks. The study is ongoing. It's a large cohort. Preliminary results in around 100 patients show excellent sustained virological response. Roberta D'Ambrosio presented similar results in Italy. She collected data from North Italy in the same regimen, glecaprevir, preventaspvir. The majority of patients, non-cirrhotic patients, genotype 1, 50%. The preliminary results again show excellent sustained virological response. There is another study by Alexandra Mangia, and there are also real-world data from the south of Italy. And the population, the baseline characteristics of the patients are slightly different. There are more patients with liver cirrhosis, more genotype 2 and genotype 3. The study includes around 1,000 patients, and they have been treated in this study with sofosbuvir, velpatasvir 12 weeks. And SVR rates were between 98–100%. So I think the type of patients are changing. At least in Europe, we have more naive, non-cirrhotic patients that can benefit for a shorter treatment duration.
And so they are easy to treat.
Easy to treat.
They are easy to treat, and so we can achieve HCV elimination in few years if you have the possibility to treat these patients with very short and very effective and very safe combinations.
Yes, we can achieve HCV elimination, but we need
to screen.
And we need to convince politicians
Absolutely.
that these regimens are very, very useful.
Yeah.
And for this reason, we need to have data on the benefits on sustained virological response.
Absolutely. No, I think it's very important to show that even in non-cirrhotic patients that there is a clear benefit to treat these patients in terms of liver disease, extrahepatic disease, of mortality. Yes, I think it's very important.
And I think in this meeting there are new and very important results on sustained virological response and the impact on sustained virological response avoiding complications.
I think that we have a very interesting study with a large cohort has been presented more than 4,000 people in this cohort, and the key point is that the goal was to evaluate the mortality related to liver events, but also to assess the mortality related to cardiovascular disease. So for the liver, clearly the SVR rate is associated with an improvement of survival. So I think it's very important to show that. And it's very clear for patients with compensated cirrhosis, meaning child A cirrhosis. Another important factor is the albumin level, meaning that in patients with albumin lower than 35, the survival is slightly lower, meaning that in child B patients, the outcome in patients who achieve SVR is uncertain, and it's not clearly demonstrated that SVR has a positive impact in patients with decompensated cirrhosis child B. But clearly in child A we have a decrease of the mortality due to liver events.
I like this study because this was a prospective study.
Absolutely.
It's performed in Sicily,
Yeah.
large number of patients, and all of them were treated with DAAs. So I think clearly collect the outcome of these patients. The majority are cirrhotic patients, child A. They have been followed for a time, and during this follow-up, it's clear that the factor that has a main impact on survival is sustained virological response.
No, I think really it's a very important message, and it's very robust, a large number of patients. And the point is really correct. All patients were treated with DA, so it's a real benefit of the DA treatment and the SVR in this population. And the second point of this study is the impact on cardiovascular disease. And I think that it's very important because based on a French study, we have seen that cardiovascular disease was less frequent in patients with SVR compared to those without SVR. However, the majority of the patients were treated with PEG interferon and ribavirin, and we know that metabolic syndrome, diabetes is a major predictor of SVR. So it was very difficult to know if the benefit, the positive role was related to SVR or was related to the selection of patients without diabetes, patients who respond to PEG interferon and ribavirin. And again, in this very large cohort, we see that the SVR is associated with a decrease of cardiovascular mortality. So it's very important. SVR is associated with a decrease of cardiovascular mortality. So I think it's a very important message. All patients were treated with DA. And the second...
and as you know, the group of Antonio Craxi, that is the same group of this study, has shown some years ago that patients with hepatitis C have an inflammatory state, and this is associated with more risk of cardiovascular events. And they have studied by echo Doppler, atherosclerosis, and I think these are very preliminary results that need to be confirmed in further studies, but probably there is possible an association between sustained virological response and decrease in cardiovascular events.
I fully agree with you. No, I think really it's clear. And the second point is that in this study, the other factors related to mortality was diabetes. And we know that diabetes has a negative role in cardiovascular disease and probably also in the occurrence of HCC. So, and we have also another important study from Scotland, because they have treated approximately 5,000 patients, and it's very important because they show that with the DA and with the SVR obtained in the patients with the DA, there is a decrease, a significant decrease since some years of hepatic decompensation. So clearly we show the positive impact of DA and SVR in the population and in the occurrence of decompensation.
This is important because they have shown these results for first time in a country level. And clearly, these are very important tools for combines our healthcare payers. That treatment is very important. In Catalonia, we have seen a decrease in the number of liver transplantations related to liver decompensated disease. We still have some patients with hepatocellular carcinoma, as you have said before, but clearly we have less and less decompensated patients, and this is the positive effect, the impact of DAAs.
Yes, so we have observed exactly the same thing in France for liver transplantation related to HCV, and it has been published, I think, in the US. We have a very nice study showing that there is a decrease of liver transplant in HCV patients. So yes, it's very important.
Clearly, we have to go to hepatitis C elimination, and now we have more and more data that is a cost-saving strategy.
But now we must move to HBV. So what's new in the HBV field, Maria?
Wow, hepatitis B, it's a more difficult virus than hepatitis C, and it's more difficult to cure hepatitis B than hepatitis C. We have new data on the current treatments, and the last treatment approved for hepatitis B in Europe and in the US was TAF, tenofovir alafenamide. And this is a prodrug of tenofovir. And in this meeting, we have shown important results in patients treated with patients treated with tenofovir that switched to TAF. And after switching to TAF, these patients were evaluated for the presence of renal alterations and also a special evaluation for bone disease. And the study shows that in these patients, for both patients with potential risk factors for tenofovir toxicity and in patients without risk factors, that switching to TAF is associated with an improvement in renal alterations and in bone mineral density. So we have more and more data proving that TAF is a better drug than tenofovir, particularly for patients with potential risk factors for tenofovir toxicity, as the last ILC guidelines recommended for hepatitis B.
So TAF is highly effective and safer than tenofovir, clearly, based on this study and other studies. So in Spain, can you use TAF?
We can use TAF, but still are waiting for the reimbursement. So we can ask for TAF for special patients. But I think all of this data, and there are populations that clearly are going to benefit from TAF, and another population are liver transplant patients. These are patients that are with some drugs that potentially have renal alterations. So I think all of these studies, and there have been several studies presented on TAF that clearly show a benefit to switch to TAF. And this will be an important drug in the future for hepatitis B.
And for you, what are the best candidates for TAF?
The best candidates are older patients, patients above 60, patients with renal alterations, or patients taking drugs with potential renal alterations, patients with bone disease, osteoporosis, osteopenia.
So we have the choice in these patients between entecavir or TAF, except in patients exposed to lamivudine.
Yeah.
But so for a first-line therapy, when do you use tenofovir?
We have the choice from in naive patients. We have the choice between entecavir and TAF. But I think there is a difference. In patients treated with entecavir, we need to monitor the renal function. And with TAF, we don't need to adjust the dose. So you can use TAF without adjusting doses, like entecavir, that if the patient has a worsening in renal function, then you need to adjust the dose of entecavir. For me, the main advantage of TAF is that it's a fixed dose and it's independently on renal function. Only those patients with GFR below 15 or between 15 and 30, then you have to take some considerations. But in the majority of patients, you don't need renal monitoring.
So really, TAF is a future for Hep B, but there is another burning question. Can we stop analogs?
There is new information in this meeting about stopping analogs. A nice study performed in Greece by Margarita Papatheodoridis. She studied patients, E-negative patients with chronic hepatitis B, non-cirrhotic patients. These patients stop entecavir or tenofovir after 3 or 4 years of complete virological response. That means HBV DNA undetectable. And after stopping nucleoside analogs, these patients were followed for 1 year, and around 20% of these patients lost HBs antigen, so achieve a functional cure of hepatitis B infection. And what is nice of this study is she looks at independent predictors of HBs antigen loss. And there are 3 independent predictors. 1, HBs antigen levels at the time of discontinuation NUCs. The lower the levels, the higher the probability of HBs antigen loss. This is very, very logical. ALT levels and IP10. So I think there is a population of E-negative patients without liver cirrhosis, because you cannot do this in patients with liver cirrhosis, because some of these patients, after stopping NUCs, have an ALT flare. So it's important that you clearly know that this patient didn't have a liver cirrhosis, so you can stop, and some of these patients, around 20% of them, clear HBs antigen. If you decide to stop a nucleoside analog treatment, it's very important to assure that the patient will have a right monitoring, an appropriate monitoring. If the patient will not be able to attend visits, consultations every 2 or 3 weeks, then every 2 or 3 months, I think it's much better don't stop treatment. But if the patient like to stop or wanted to stop treatment and it will be confident with the visits, it's a good strategy to go to functional cure, because it's clear that in hepatitis B we have to go to functional cure, and that means clearance or undetectable HBs antigen in the serum. And in this line, there are very important changes, new drugs under evaluation, the majority in preclinical studies, but we started having some of them in clinical studies, in phase 2 studies. There are drugs that target different steps of the hepatitis C replication cycle. And one of the steps that have currently more drugs under development are the capsid inhibitors. These are drugs that prevent the formation of new capsids, or they allow the formation of empty capsids without HBV DNA. And so it's a way to stop viral replication. And in this sense, I think there are 4 or 5 different studies with capsid inhibitors. But one was an oral late breaker presentation by Fabian Sulim, and Fabian Sulim showed the results of a J&J 36379, that it's a capsid inhibitor that had been administered in humans in a randomized study. Patients were randomized to receive different doses of this compound versus placebo during 28 days. And during these 28 days, there is a nice virological response. It's a decline in HBV DNA levels. Even some patients, around 40% of them, achieve undetectable HBV DNA. And there is also an important decline in pregenomic RNA, in hepatitis B RNA, a new marker for monitoring hepatitis B. There were no changes in HBs antigen levels. Probably the time is too short to see changes in HBs antigen levels, and probably these new compounds need to be used with other drugs, and probably in the next step these drugs will be combined with nucleoside analogs, and for this it's important to have a better nucleoside analogs.
So it's great for HBV. We have tough for the future. Why not stopping analogs and probably new drugs? And so many hopes for suppression or elimination of HBV. What do you think?
I think for hepatitis B, we are going to need combined drugs with different mechanisms of actions. And in this sense, we have also new information on immune modulators. In hepatitis B, the immune response, the host immune response is extremely important, very important. And in this sense, we have a new drug. It's called inaragavir, and this is a compound that it has a double action. It's a RIG-I agonist, and it has an antiviral effect, but also an immune modulatory effect. And there is an ongoing study that has been presented here in this meeting, the results of the 2 first cohorts treated with this drug, this RIG-I inhibitor, for 12 weeks, a daily dose. It's also an oral drug that it's always good news. It's like an interferon, but oral and with antiviral activity. And the results of this first cohort, that is a dose-ranging study, shows a suppression, decline in HBV DNA levels. And also, they evaluate the immune response. And they evaluate the immune response looking at HBs antigen clearance profile, that it's a new biomarker for immune response, and they shows that some of these patients have an increase in this new biomarker, showing that have this immunomodulatory action. So
great.
preliminary results,
But
night
great.
results, and there is some studies showing that if you have this immune response, this anti-HBs response, this is a predictor of HBs antigen clearance. At least we're starting having some movement on hepatitis B, and this is
It's
nice.
more and more interesting.
Yeah. We have seen new results on hepatitis C, the importance of sustained virological, new data on hepatitis B, and finally, the new EASL guidelines. The new EASL guidelines for hepatitis C, and also the first time EASL guidelines for hepatitis E. I think with this, it's a good summary that was happened here in Paris.
Thank you, Maria, for sharing and for this very interesting discussion.
Thank you, Christophe, for the invitation, and have a nice day.
Okay, so thank you for watching and au revoir.